I'll start with our foundation. You have a link, magicevidence.org, in which you can find more information. MAGIC started about 14 years ago. The conception of it was in 2009 by the board members, 4 board members shown here on the right. Per Olav Vanvik, who is based in Norway, is a chief executive officer currently on sabbatical, and he's replaced by Chris Champion, that many of you in Cochrane knows. He worked in Cochrane as acting CEO of MAGIC at the moment. You have Lynn Brandt, CTO, working a lot on platforms and technical aspects, but also an MD. Gordon Guyett, that we don't introduce any longer anymore, one of the founders of evidence-based medicine, and we are fortunate to have him on our board, and myself. And Luba today is our client care director. So we started this in 2009 as an academic adventure, an academic project really, until it became more than that. In 2013, we launched MAGIC app, a platform we'll present to you. And I should add that MAGIC is strictly non-for-profit, so it's really meant to create knowledge, innovation, and spread it. And in 2018, so quite a few years ago already, we reorganized as a foundation. We have worldwide activities. We have 32 staff members currently, about 17 researchers. The base of MAGIC is in Norway, but all our staff members are spread around the world, in Switzerland, like myself, UK, Canada, USA, Colombia, and Portugal. And we are leading and contributing to large collaboration projects with hundreds of partners. I'm sure several of you on the call today. And the MAGIC app that we'll present to you has a lot of users, more than 60 organizations using it, and soon about 200 large public guidelines. And this one figure to explain the scope of our activities and how they're linked together. First, we conduct research and innovation. I said it started as an academic adventure, and it still is. We undertake research and innovation on EBM, on methods, working a lot with the GRADE working group in particular, and partners. And we think about formats, about presentation issues, about methods to move into decision-making, up to sharing it with patients in shared decision-making. And so this research feeds the second objective shown on the screen. We try to implement all the results of our research in the MAGIC app platform so that any users can benefit from that research in their EBM activities. And with this platform and with the methods we contribute to, we have a third objective, which is to equip organizations to provide support on how to implement those innovations in their workflow, in particular to create trustworthy guidance. And as I hope to present today, we try to move a little bit further in the ecosystem towards implementation support, how to create change or even de-implementation. So all of these objectives have to work in what we call an ecosystem, the evidence ecosystem, and I'll say some more about that. Before presenting the ecosystem, there are 5 key issues, problems, challenges, if you like, that we are particularly interested in. The first one is that we notice that our community is fragmented. There's a lot of duplication of effort that everybody is aware of. There is inefficient sharing of data and resources. We do share them oftentimes, but not as much as one would hope. And there is frequent breaks in the chain of evidence as a result. In particular, because we're interested in guidance in how evidence can influence decisions, it's hard to produce trustworthy guidance. And there's various reasons for that. The methods for guidance and the standards are challenging. I mean, there's great progress in methods, but they're not that easy. So MAGIC was born in order to try and help, for example, GRADE be implemented in our practices. But it remains challenging. And many groups are working in outdated ways, using inefficient tools and processes. So this is another problem in the ecosystem that we notice. It's not easy to reuse the data, in particular when the data is not digitally structured. It needs to be digital in order to be easily shared and reused. So this is another challenge. The evidence, guidance, and tools are rapidly outdated, everybody's problem, and living evidence and guidance is one attempt to resolve that. But to the degree it's not up to date, evidence is not reaching patient care efficiently. And there's a lot of new innovation. We present a few. AI is a huge innovation, providing tremendous opportunities, as we all know, and Magic also explores avenues of AI, but it requires the same level of scrutiny and rigor, and AI in itself doesn't solve all the other issues shown on the screen. So this is a way to conceptualize the evidence ecosystem that we use, and we hope it can be helpful, is to recognize there are different partners, different key stakeholders working in the evidence ecosystem. One of them is the evidence producers. And by the way, we can be in several of those categories, of course. Producing the evidence is conducting the research itself, from fundamental, translational, and clinical research, the clinical one being the more ready to use and implement. The second aspect is core to Cochrane. Cochrane, of course, is evidence synthesizers, doing systematic reviews, meta-analysis, network meta-analysis, with all the methods and challenges we know. Third partners are the disseminators to clinicians, in particular guideline makers. All the panels, all the people working on evidence synopsis, evidence summaries, resources, are trying to use the research and the synthesis of research to try and move to guidance for decisions. But they're not yet the decisions. The decisions are hopefully made at the center of the ecosystem between healthcare providers and patients. So we also have a community, many of us working to disseminate the evidence directly to patients in various forms. Of course, decision aids, all the shared decision-making community, patient information in itself, everything related to media and social media that has rapidly evolved. Then we have the bravest, I think. We're all brave in the ecosystem, but the ones that try to implement change, to really go where the challenges are, using old and new ways of doing it, clinical pathways, dashboards, audit and feedback, all the toolkit that implementation science is developing, and the need to do research on implementation itself, to know what is working, to have evidence-based implementation. And of course, with implementation goes evaluation, constant evaluation, to create a loop. And so I'm hoping to show through this simplified presentation, of course, that there is a flow through the evidence ecosystem, which is the data that becomes information, knowledge, in using all the methods of evidence-based care. Now, in order for this to happen, you need a lot of things in the background. And this is one way of conceptualizing it, through these cogwheels in the middle of the evidence ecosystem. You need sound methods for each of these aspects, as I mentioned, not just methods for the research, but methods for synthesis, methods for guidelines, methods for shared decision-making, methods for implementation, methods for constant evaluation. And in order for us to really be an ecosystem, we need to agree on at least a core set of standards and methods to work across them. And GRADE is certainly one attempt to touch base on a few of these methods. You have tools and platforms, and we'll present ours, that digitally structure data in order to have this evidence flow and be shared. This requires coordination and support and training. Everybody tries to make methods and tools as intuitive as we can, but there is advanced methodology and a need for everybody to receive training, basic and advanced, to implement those methods. There is patient partnership, and I put it at the center because it's developing fast and it probably is very insufficient. And in many of our projects, we try to have patient partnership at the core of our endeavors. And finally, and the last one is equally important, is a culture of innovation and sharing. The need to progress and to share what we make. And of course, this opens a doorway towards shareable data, access of data for everyone, including in countries with lower resources. So this is a way of conceptualizing the ecosystem and what plays within. In this talk, we cannot dive into all these aspects, but we'll suggest a focus on methods and tools and platforms today. So if I talk about methods, I've alluded already, Cochrane has developed lots of methods in the synthesis world. GRADE in the evidence synthesis and guidance has been quite a revolution for a few decades now. And standards for clinical practice guidelines, for example, from the Institute of Medicine. And those methods are needed because healthcare professionals and their patients need trustworthy, timely, and accessible guidance every day. We make decisions with patients every day, so we need that to be at the top level. And so there's definitely been huge progress in those methods. I've alluded to GRADE guidance, both in the BMJ and in the Journal of Clinical Epidemiology that many of you are aware of, provides a lot of granularity in how these methods could be applied and should be applied. But we also know that the reality is not as good as we hope. We're always a little bit behind. And if I focus on guidelines, on the standards of trustworthiness that the Institute of Medicine issued in 2011, we know that's a bit outdated, but it still considerably applies, that half of the guidelines taken randomly apply less than half all the trustworthiness criteria and methods criteria. So there is a lot of progress to do, and there is a lot of conflict of interest, as we also know. So one of the innovations that MAGIC has led are the BMJ, British Medical Journal Rapid Recommendation since 2016. We worked in close collaboration with a journal, which is also an innovation to say journals are not just here to disseminate products from the evidence ecosystem, but actually partners within the ecosystem to co-create with us those methods and formats for trustworthy, timely, and actionable recommendations. And if you Google rapid recommendation and BMJ, you'll find one of the landing pages on the BMJ providing examples. Those are didactic examples we've chosen in screening, primary care, drugs in acute care, and devices that are not chosen randomly. They're chosen because they have a potential for practice change or methodological challenge in which we need to innovate together. So I won't read them all, but you see them on the screen. Recommendation about screening, about treatments for primary care and drugs in acute care. A lot of interventions that led to recommendation to stop them, recommendation against the interventions in a de-implementation strategy or choosing wisely strategy. One key example, for example, is arthroscopic surgery for degenerative knee arthritis. And Luba, I think, will present an example in MAGIC app using that one, and devices. So throughout this presentation, you see some examples that are taken from the guidelines that MAGIC produces. MAGIC helps guideline makers do their guidelines, but we also produce those guidelines with independent panel members internationally. And one of them is a WHO guideline on therapeutics for COVID-19. I'll also show an example. So we need to agree on those methods, and we need to develop those methods further within the evidence ecosystem. Tools and platforms are central to digitalize the data, and this is our response to this issue is the MAGIC app. So MAGIC is an authoring and publication platform that I already mentioned is now widely used and increasingly used, but it is also our lab. When I said we conduct research on presentation formats, processes, we try to embed them into something concrete that users can engage with and use with then in their own projects. And conceptually, MAGIC has an authoring side where the evidence is structured into different pieces the data from the studies, the PICO, the recommendation, the key information, the rationale, and you recognize the structure of grades behind this authoring and this tagged content that can then be presented in many different ways on multi-layered format for clinicians in their care, in their daily practice, integration in the electronic medical record, adaptation, and MAGIC was born from the need to adapt internationally produced guidelines into one of the first guidelines was for Norwegian context, for Norway, and decision aids for shared decision making. I'll say a few words, and a few years ago, we presented pilot work on this Share It project, how to present the evidence and to share it with patients in formats directly to be shown with patients at the point of care. One spin-off of Share It has been an important finding. It's the central importance of practical issues. And we've developed in MAGIC a framework for structuring practical issues around interventions in particular. And this framework was based to produce shared decision-making tools, but also to structure the evidence. And if you haven't had a chance to read our paper on that, I invite you to do so to see more concretely how we can do it. But we really found out from large databases 15 categories of practical issues that are now digitally structured in MAGIC itself to be used in the ecosystem. And in this framework, you recognize in the last part of the figure shown here, elements of daily life, food and drinks, exercise and activities, work and education. So how interventions, healthcare interventions impact those activities that patients talk about and that are central to their decision-making. But also in the first line, for example, everything that we do in the healthcare context.